Respiratory Physiology, Ventilation and Perfusion Relationships. Welcome, listeners, to today's episode, where we explore one of the cornerstones of respiratory physiology, the intricate relationship between ventilation and perfusion, and how this interplay shapes the efficiency of gas exchange in the lungs. Introduction. The matching of air and blood gas exchange in the lungs is far more than the simple diffusion of oxygen and carbon dioxide across the alveolar membrane. It is a dynamic process that relies on the harmonious pairing of ventilation, the movement of air into and out of the alveoli, with perfusion, the flow of blood through the surrounding capillaries. The ratio between these two processes is known as the ventilation-perfusion relationship. In an ideal scenario, every region of the lung would receive a perfectly balanced mix of air and blood. However, the reality is much more complex. Due to gravity and the unique anatomy of the lungs, the distribution of ventilation and perfusion varies significantly throughout the organ. The lungs have developed remarkable mechanisms to minimize any mismatch between these two flows, and thereby preserve efficient gas exchange. Regional differences in the lung. The zones of the lung. Let us begin by considering how gravity influences the lungs when we are upright. At the base of the lungs, blood flow is at its highest because the hydrostatic pressure is greater. This increased pressure distends the capillaries and allows more blood to circulate at the lower regions. Conversely, at the apex of the lungs, the hydrostatic pressure is lower, resulting in reduced blood flow, and at times, the small vessels may even collapse for brief moments during the cardiac cycle. Ventilation, or the distribution of air, is also greater at the base than at the apex, but for a different reason. The weight of the lung causes the pressure in the pleural space to be less negative at the base, which means the alveoli in this region are less expanded at rest. During each breath, these alveoli have more room to inflate and thus receive a larger share of the incoming air. At the apex, the alveoli are already more expanded and do not inflate as much during inspiration. This creates a spectrum of ventilation-perfusion ratios throughout the lung. At the apex, the ratio is high because ventilation exceeds perfusion. As a result, the composition of gas in these alveoli closely resembles the air we inhale, with high oxygen and low carbon dioxide levels. At the base, the ratio is low. Since perfusion outpaces ventilation, the air there is comparatively less rich in oxygen and contains more carbon dioxide, resembling the composition of mixed venous blood. In the middle regions, ventilation and perfusion are reasonably well matched. Local automatic control. How the lungs balance air and blood flow. The lungs possess sophisticated automatic controls to correct local imbalances. If an alveolus receives too little ventilation, perhaps due to a mucus plug, its oxygen level drops and carbon dioxide accumulates. The body responds by constricting the small arteries supplying that region, redirecting blood flow to better ventilated areas. This process is known as hypoxic pulmonary vasoconstriction and is vital to maintaining adequate oxygen levels in the blood. On the other hand, if an area of the lung receives insufficient blood flow, perhaps due to a small clot, the carbon dioxide level in the affected alveoli falls. The airways leading to these alveoli respond by constricting, diverting air to regions with healthier blood flow. This mechanism ensures that ventilation is not wasted on areas where it cannot contribute to gas exchange. The extremes of mismatch, shunt and dead space at the ends of the ventilation-perfusion spectrum are two critical conditions. A shunt occurs when blood flows through the lungs without encountering any ventilation. For example, if an airway is completely blocked, this blood passes through the lungs without being oxygenated, mixing with the oxygenated blood and reducing the overall level of oxygen in the arterial circulation. Importantly, shunted blood does not respond to additional oxygen therapy, as no air reaches the affected alveolus. Dead space represents the opposite extreme. Here, ventilation occurs in areas with no blood flow, such as in cases of pulmonary embolism or severe emphysema. The air that reaches these regions does not participate in gas exchange and is effectively wasted. Dead space is a combination of air in the conducting airways, which is always present, and air reaching unperfused alveoli, which occurs in disease states. Consequences of ventilation-perfusion mismatch. Ventilation-perfusion mismatch is the most common cause of low oxygen levels in the blood, known as hypoxemia. In lung disease, it has a profound effect on oxygen exchange, as regions with low ratios dump poorly oxygenated blood into the systemic circulation. This reduces the average level of oxygen in the arteries. The effect on carbon dioxide, however, is less marked. The body can compensate for rising carbon dioxide levels by increasing overall ventilation. but it cannot fully correct the oxygen deficit caused by shunted blood. This explains why many patients with chronic lung diseases experience low oxygen levels without a significant increase in carbon dioxide, until their condition becomes very advanced. Summary to conclude. The relationship between ventilation and perfusion is fundamental to efficient gas exchange in the lungs. There is a physiological gradient in the ratio from the top to the bottom of the lung. Automatic mechanisms such as hypoxic vasoconstriction and carbon dioxide-mediated bronchodilation work tirelessly to fine-tune the match between air and blood flow. At the extremes, shunt and dead space represent pathological mismatches, with important clinical consequences. Understanding these relationships is essential to appreciating the complexities of respiratory physiology and the challenges faced in lung disease. Thank you for joining us in this exploration. Stay tuned for more deep dives into the wonders of human physiology. It's the Everything Surgery Podcast. Dissect the extraordinary.